Welcome at the Forefront of Food Allergies, Preventive Strategies to Improve Outcomes, presented by Partners for Advancing Clinical Education in collaboration with the Asthma and Allergy Foundation of America and FAIR, Food Allergy Research and Education, broadcast in Immunology Live. This is the second session in a two-part series entitled Defining the Place of Emerging IgE-Targeted Therapies in Team-Based Management of Food Allergies. My name is Dr. Robert Wood, and I'm Professor of Pediatrics and International Health and Director of the Wood Division of Allergy, Immunology, and Rheumatology, as well as Director of the Pediatric Clinical Research Unit at Johns Hopkins University School of Medicine. I'd now like to introduce my co-presenter, Dr. Jennifer Dancer, who is an Assistant Professor of Pediatrics in Pediatric Allergy, Immunology, and Rheumatology of the Johns Hopkins School of Medicine. Thank you, Jen, for joining me today. Before we get started, a reminder to visit the event resources section of the player located in the video box to download today's presentation slides, as well as some resources you can share with your patients provided by the Asthma and Allergy Foundation of America and FAIR. Now, let's get started. A brief disclosure slide to say that Dr. Dancer has no relevant financial relationships to disclose, and Dr. Wood has research support from a number of companies, including Aimmune, ALK, DBV, Novartis, and Chiolta. Learning objectives for today's session are as follows. Number one, describe current evidence supporting the efficacy and safety of emerging biologics that target the underlying pathophysiology of food allergies and common comorbidities, and to summarize strategies to develop a multidisciplinary, patient-centered approach to the management of people with food allergies and other immunoglobulin E, IgE-mediated comorbidities. We're going to begin with a little discussion of the scope of the problem. And what every one of you knows, we're out there seeing patients, that food allergy is very common. And the current numbers are affecting up to 8% of children and adults. That means that there are somewhere around 32 million Americans who have IgE-mediated food allergy. And importantly, at least 40% of them, possibly as many as 80%, are allergic to multiple foods. As we know, food allergy requires constant vigilance in an effort to avoid reactions and to treat reactions if they occur. We also know that food allergy can have significant effects on nutrition, economic burden, and overall quality of life. Jen, I'm going to turn it over to you for a case presentation.
Great. So now let's talk about a case example of something that would be fairly typical for what we may see in clinic or you may see in your clinic. So this is the case of an 8-year-old who came to clinic with her father for follow-up after she had an immediate allergic reaction when she had accidentally ingested a food that contained milk. So she was at a party and took a bite of a cookie that she thought was safe. And then within 10 minutes, her mouth became itchy. She developed hives, a runny nose, and cough. Her parents gave her an epinephrine auto-injector and called 911, and her symptoms did improve quickly. She has a documented history of allergy to peanuts, tree nuts, and milk. So we will circle back to this case later in the presentation. But this kind of lays the groundwork for a typical patient that we all may see. So now we'll talk just a little bit about the underlying pathophysiology of food allergy. So allergic responses are characterized by a Th2-driven immune response. In predisposed persons exposed to certain allergens, IgE antibodies specific for food are formed. These antibodies bind to effector cells such as basophils, macrophages, mast cells, and dendritic cells. And once the food allergens are ingested and then reach the cell-bound IgE antibodies, it can create this cross-linking. That cross-linking on the effector cell then causes that cell to release their mediators such as histamine, prostaglandins, and cytokines. And the release of those mediators is then what triggers symptoms of an immediate IgE-related response, such as vasodilation, flushing, wheezing, and all of the things that you would think of with a typical allergic response. So now we will switch back to Dr. Wood, who will discuss an overview of current treatment options.
Thanks, Jen. So it still turns out that for the vast majority of patients, food allergies managed through strict avoidance and the use of emergency medications in the event of accidental exposures. And while this can be successful, and it is actually an approach tested by time eternity, accidental ingestions are common, even in the most cautious patients. And this turns out to be especially the case for certain foods that are more difficult to avoid than others, like milk and eggs. We know that reactions, even with small exposures, are often severe and can even be life-threatening. And we know that successful avoidance requires planning for all food-related activities on a daily basis, which may sound simple, but when you think about the way food and you and your children interact on a daily basis, it is incredibly complicated. Right now, we do have one FDA-approved treatment for food allergy, and it's in the category of oral immunotherapy for peanut. There's also off-label use of food products to provide OIT to other foods and even to peanut. And what is happening here are that foodstuffs are purchased literally in a grocery store and given in a way that will gradually, hopefully, induce some level of desensitization. Now, there are some pros of OIT, and that is that it has potential to desensitize most patients. So in many studies for a variety of foods, it turns out that a majority of people can be desensitized to a level that might protect you at least from small accidental exposures. The downside, the cons, are that the risk may well outweigh the benefit. And the risks that we're talking about are that 10 to 20% of patients being treated with OIT will have a severe reaction to a dose on any given year. And even more common, and actually the most common reason to stop OIT, is the development of chronic abdominal symptoms. And this can be vomiting, it can be abdominal pain, but it is not just something where your stomach hurts for a few minutes after taking your dose. It's that your stomach basically hurts 24 hours a day, unrelated to your dosing. And we know that some subset of these patients with chronic abdominal symptoms will have eosinophilic esophagitis, an actual inflammatory condition of the esophagus that has been induced by exposure to the foods to which that patient was allergic. Other disadvantages of OIT is that it requires complicated dose buildup, it requires daily dosing, and as far as we know right now, for most individuals, treatment will be a lifetime plan as allergy is known to return once treatment is stopped. We'll go back, Jen, to the case presentation. Maybe you can give me a couple of highlights that you'd like to bring out from this patient that represents literally hundreds of kids that we know.
Yeah, so I think this patient highlights just what an impact that food allergies can have on multiple realms of a patient and a family's life. It kind of requires that constant vigilance, trying to keep yourself or your family members safe. It requires kind of very careful planning as food is constantly around us and at multiple social activities. And then we know that sometimes even when people and families do their best, that accidents can still happen, which was the case in this case presentation. And so I think all of these reasons just highlight why we need better and more effective treatments for our patients.
Yeah, I think the other aspect of this that is sort of hidden within the case is that while people in general, physicians, pediatricians, have all sort of grasped the idea that peanut allergy is a big deal, that it's common, it can be life-threatening. But what is often underestimated is just how dangerous allergies to other foods can be. And families with milk allergy are still, even here in 2023, very frustrated by the fact that the people around them, whether it be the teacher at school or even the nurse in the emergency room, may not actually understand that her milk allergy may be just as dangerous as the worst peanut allergy out there. And we know from the prevalence of milk in the diet of people in America and around the world that avoidance is difficult enough that it's likely that family cannot even go out to a restaurant safely, and really highlights the need for some form of treatment that could make their life safer and ideally give them a level of protection that would have prevented this actual severe reaction. So let's move on and talk a little bit about some emerging treatment options. And this is a topic that has been very, very hot for a long time, but we do see it moving in a somewhat different direction right now, in a very exciting direction that I'd like to describe in the next few minutes. So there are a lot of approaches of treatment under study. And we're going to divide those generally as to those that are food specific, i.e. focused on one individual food, versus those that are non-specific, that is, might protect equally against any type of food allergy. So on the food specific side, there is something called epicutaneous immunotherapy, or EPIT. It's also been popularly referred to as the peanut patch. And what is happening here is that the patient is actually wearing a Band-Aid sized patch that is impregnated with a small amount of peanut protein. And by wearing that 24 hours a day, the EPIT has been shown to build some degree of protection in a majority of patients. It tends to work far better in younger patients, and that the next study that is coming out on EPIT is focusing just on a narrow range of 4 to 7-year-olds, where there appears to be the greatest chance of efficacy. Sublingual immunotherapy refers to taking small amounts of a food under the tongue, taking advantage of a very rich immune environment in the sublingual space. And the encouraging thing about sublingual immunotherapy is that results from studies do show that most patients can achieve some degree of protection, probably even close to or equal to that provided by oral immunotherapy, but by taking very small doses and lessening the risk of anaphylactic reactions. There's a new product called VLP, virus-like particle peanut, that is under a clinical trial right now. And this is one of many strategies that are emerging as the pharmaceutical industry becomes more interested in food allergy as a target population. Peptide immunotherapy refers to a way of producing an allergen such that you've kept the parts of the protein that would be required to induce some degree of desensitization or tolerance, but trying to remove the portions of the protein that lead to IgE binding and adverse reactions. And interestingly, there's a new study that was started in Australia and is now moving to the United States with a specific peptide immunotherapy product. Again, food specific and only focused on peanut. Another similar approach, but a little less sophisticated, is to try to chemically modify the peanut protein in a way that you could essentially do the same thing. That is, try to modify the parts of the protein that will lead to adverse reactions and keep the parts that are important to induce tolerance. And lastly, there is interest in using IgG4 antibodies as a means to block food reactions. And one of the interesting things we see in the studies on treatment with something like oral immunotherapy is that the immune system produces a lot of IgG, especially IgG4, which may actually be part of the reason that the allergic reactions are being blocked or at least limited. And there is an effort here with a company to produce a high dose specific IgG4 antibodies that could work in the same way to block reactions to peanut and potentially other foods. On the nonspecific side, the list is shorter, but very important. And one is a class of drugs called BTK inhibitors that have been used for treating things like malignancy in the past, but have been shown to have an effect to reduce or even eliminate, in some cases, allergic reactions on exposure to the problem food. And we're going to talk the rest of the time here about biologics. And biologics have led to a revolution in medicine where many diseases now rely on biologics as the mainstay of treatment. So whereas patients in the past, if they had, say, severe autoimmune disease, might be stuck on long-term steroids, they now may be treated with a very specific biologic that will attack the pathways in the immune system that are responsible for that individual's disease. And here we're going to talk about biologics for food allergy. Now, what are the potential advantages of a biologic? And I'm going to stress the idea that an advantage here is that they are not food specific. And when Dr. Dancer actually did a recent study trying to identify the reasons that oral immunotherapy for peanut has not been a big seller, it turned out that a lot of patients said, well, I'm allergic to so many things, and actually peanut might be the easiest thing for me to avoid. So what I really care about is something that will treat all of my food allergies and not just a single food. An advantage is that it's intermittent dosing as opposed to the daily dosing that's required for something like SLIT or OIT or EPIT. There's a long track record of safety, especially for, in this case, omalizumab, a drug that was actually approved in 2003 to treat asthma, and therefore has now 20 years of experience with a very reassuring safety profile. One of the things that we sometimes overlook until we actually sit in the room with the patient is that all of our patients virtually with food allergy have other allergic problems. We refer to them as comorbidities. So a majority of patients, say in our studies of peanut allergy or multi-food allergy, have eczema, asthma, allergic rhinitis, or a combination of all three. And some of these things, especially asthma and allergic rhinitis, can actually be nicely controlled with the use of anti-IgE antibodies. So a patient may get the benefit of protection from food allergy as well as treatment of their comorbidities. Efficacy is here with a question mark because we are still awaiting the final studies to hopefully demonstrate efficacy. But what we know now, though, is from about 30 different studies using omalizumab or potentially other anti-IgE molecules, we see that there has been real effects on food reactions with the use of these medications. And the question efficacy here is really related to whether a phase 3 trial that is currently underway will demonstrate sufficient efficacy that this may be taken to the FDA to get a label for food allergy for omalizumab. And then as pediatric allergists, our dream is always, can we modify disease? And that is something that will take longer to know, but we're always interested as to whether we are just treating a condition, which is what most allergy treatments do, or whether there might actually be a potential to modify long-term disease. There are disadvantages. One of them is requires long-term use, but I already told you that the other treatments probably require lifetime use. So this is really just part and parcel of how we treat allergy, which is that we don't generally cure things, and we do usually require long-term maintenance, whether it be in an immunotherapy or a medication. There is a disadvantage of having dosing restrictions, and our patients with very high IgE levels may not be able to receive omalizumab or other anti-IgE products because of the concern about using these drugs in patients with IgE levels that are too high. And too high has generally meant something above 2,000 when we're talking about food allergy. And lastly is cost. And all of these biologics are expensive. So it's very important that we be balancing costs with the benefits that these products may provide. So biologic understudy is omalizumab, which is being studied and has been studied as monotherapy or as adjunctive therapy. And for adjunctive therapy, we're talking about using it along with oral immunotherapy to help reduce reactions caused by the OIT. And the study that is currently going on is looking at patients with allergy to peanut and at least 2 other foods. And ligelizumab, a similar anti-IgE product, is also in a phase 3 trial looking at patients with peanut allergy. This is a study that was now done over 20 years ago, looking at a different anti-IgE product called TNX-901 for the treatment of patients with peanut allergy. And what was shown in this study is that after getting 3 doses of TNX-901, especially at the medium-high dose and the very high dose, there was a substantial increase in the threshold of peanut it took to cause a reaction, going from about half a peanut to 9 peanuts. And this is something that really generated a huge amount of interest with the New England Journal publication 20 years ago, but never unfortunately moved forward for a variety of reasons until the more recent past, when we were able to begin this study called COFAR-11. COFAR stands for the Consortium of Food Allergy Research. And the study is looking at omalizumab either as monotherapy or along with multi-allergen oral immunotherapy. So this is a phase 3 collaborative trial involving 10 centers. It's randomized, double-blind, placebo-controlled with 225 participants. We're looking as young as 1 year of age, as old as 55 years of age. And to be enrolled, you had to be allergic to peanut and at least 2 other foods. And those were from milk, egg, wheat, cashew, hazelnut, or walnut. And interestingly and importantly, omalizumab was granted breakthrough therapy designation by the FDA before the Outmatch study actually started. And the goal here, as I mentioned, is for the potential approval of omalizumab for the treatment of multiple food allergies or any food allergy in patients as young as 1 year of age. The current study status is that 180 have been randomized, and because there was from the FDA a grant of early analysis, the final study size for the double-blind placebo-controlled phase 3 trial will be 180. There were 68 randomized age 5 and below. And again, we're hoping for results in the fall of 2023. And we think that this study will really help to inform the optimal use of this treatment, as well as future anti-IgE medications and possibly other biologics for the treatment of food allergy. So we're thinking about the next 5, 7 years, 10 years, 20 years. What can we do that's been better than what we've had before? And this is going to involve assessment of individual patient goals. And Dr. Dancer is going to talk some about these patient goals and how shared decision-making is going to be so important. We think that for some patients who, I'm going to say in quotes, have simple food allergy, like I'm only allergic to peanut, they may prefer continued avoidance as the best option for their treatment at the present time. But we should be able, we hope, to have a treatment option so that we can actually bring shared decision-making to the pediatric clinic. And this will depend on available products, their expected risks and benefits, and then individual characteristics. What is the ideal age? Are younger kids better to be treated, or should we just wait until risk is higher in the teenage years or college? Reaction history. Are you someone who's reacted to very small exposures? Anxiety and effects of disease and the treatment on quality of life. What are your specific food allergies? There may be some, as I mentioned, that are harder to avoid and more appropriate for treatment. Additional factors may make treatment more difficult, such as college itself may be more difficult, or travel to less developed countries may make it far more difficult. Then lastly, as we mentioned, comorbidities. And with that, I'm going to pass back to Dr. Dancer, who's got some very interesting information on a team approach to our patients with food allergy and to shared decision-making.
Thanks. So as we mentioned earlier, there are a lot of people with food allergies. And so really to provide the best care for these patients, we do need a team approach with the allergist and with their primary care provider. And you know, we think that this is a very exciting time in food allergy management where families and patients may finally have a treatment option. And it's going to be very important that both the primary care provider and the allergist have a role in understanding what is the patient preferences and their needs and what is going to be the best treatment for them. And then it's also important to consider that there can be spillover effects on parents and siblings that may impact decision-making with respect to food allergy, and that these effects can change over time depending on the age of the pediatric patient, the age of the sibling. So lots of different factors to consider. So I think one of the key things is to make sure and always remember the patient's voice. And then in pediatrics, we also want to remember the parent's voice and other family members' input. And so shared decision-making can be defined as a process whereby the patient and family and the clinician meet to mutually explore the risks, benefits, alternatives, and other considerations regarding a medical decision. So this exchange of information between parties allows the patient and the family to clarify their values and preferences regarding a diagnostic, treatment, or management option. And then the goal is really to make an informed decision that reflects their goals, their values, their preferences, and their desires. So there's been a robust expansion and incorporation of shared decision-making into food allergy practices in recent years. This includes food allergy prevention, so early introduction and how to approach that with different families. Shared decision-making is often used in deciding whether a family would like to do an oral food challenge, and then now will hopefully be incorporated into helping make decisions about food allergy therapies. So talking a little bit more about shared decision-making. So as these new therapies become available, it's going to be very important to ensure that the patients and the caregivers understand their options. So as Dr. Wood mentioned, to date, no treatment option appears to be a cure. So wanting to ensure that they know benefits, risks, and then both short and long-term treatment considerations. Also talking with them, and this can be something done by both the allergist and the primary care doctor, but to understand what do they hope to get out of the treatment and what is their overall preferences. And then when considering the IgE-targeted therapies, Dr. Wood already discussed a lot of these factors, but thinking about some things such as comorbid conditions, their risk for severe reaction, with all of the things listed there that have been touched on already. And so one way that we can work together to help families with this is the use of decision aids. So decision aids have already been developed to help assist families with determining goals and preferences and understanding options for oral immunotherapy. And we anticipate the creation of new decision aids once additional treatment options are approved. And here's just two small examples of kind of the key parts of most decision aids. So one is just making it very clear to the family what are the benefits and what are the risks and side effects. And then as you can see in this example, they do a nice job of presenting the information in multiple ways, so words and pictures, to help make sure that it is as clear as possible. And then a second part is often having some questions that just help guide a discussion about what would be their treatment preferences, both short and long term, to help kind of steer them in the correct direction going forward. So shared decision-making in general is a concept that's been utilized in multiple fields. I'm sure that all of the providers, both allergists and primary care providers, are using this in other aspects of patient care already. And this, we think, can also be incorporated to food allergy treatments with the big concepts of involving the family, keeping them informed, trying to make sure that there's information available for a variety of different health literacy levels, and then having these discussions and then kind of working again together to move forward. And this last slide that I have just highlights some of the things that the primary care provider can do and the allergist. So as the primary care provider, you can discuss goals and food allergy treatment preferences with the family. You can share resources about treatments and decision aids when those become available. You can help update patients as new treatment options become available. encouraging regular follow-up with their allergist, and then it may be an option in the future to administer some of these therapies in the office. And then as the allergist, so our role is to have detailed discussions with the patient and families about risks, benefits, and other considerations of these treatments, to review their eligibility for therapy, and then would be to initiate and manage the treatment if selected. So just to review some of the key things that we talked about today. So food allergy is common. We know that it has significant effects on quality of life and is associated with significant morbidity. Ideally, treatments will emerge that provide significant protection with acceptable risk and ease of use. And at this point in time, biologics directed at the blockade of IgE come closest to meeting these goals, especially related to their safety profile, ease of use, apparent efficacy, non-food specific effects, and effects on comorbidities.
Thanks, Jen. So I want to remind you to join us for another CME session entitled Management of Food Allergies, Guideline-Based Prevention of Allergic and Anaphylactic Reactions, of which I will be part along with Dr. Edwin Kim from the University of North Carolina. So I want to thank all of you for participating today. I want to thank Jen, Dr. Dancer, for her excellent presentation. I'd like to thank Genentech for their support to this important educational activity. I do want to remind you to visit the event resources section of the player located under the video box to download today's presentation slides, as well as some resources to share with your patients provided by the Asthma and Allergy Foundation of America and FAIR. Please also remember to complete the post-test at the end of the session to secure your CME credit. Please visit immunologylive.com to review today's session, along with other sessions on demand. Again, this is Robert Wood, and thank you very much for joining us.